I think it's recognizing that cancer care extends beyond the initial diagnosis and the initial treatment. People can live for years. Thankfully, like our treatments are getting better and better, and people are living longer and longer with metastatic breast cancer.
The oncologist-patient relationship is just different. It's like you're helping me live, and thank you for saving my life. I literally would not be here without you.
You did all the hard work, Samira.
I really did. Welcome to The Patient from Hell, the show where we discuss real stories, expert insights, and build a community that every cancer patient deserves. I'm your host, Samira Daswani, a bioengineer, an entrepreneur, and a cancer survivor. Today, we're diving into the world of survivorship with Dr. Fauzia Riaz, an oncologist and researcher from Stanford University. She was also my oncologist that saved my life. Back in 2020, when I was diagnosed with breast cancer, Dr. Riaz spent over 2 years treating me. She was patient, kind, and answered my thousands of questions. In this episode, we explore the different types of survivorship plans, Dr. Riaz's research interests, and the unique challenges that survivors face. Let's get started. I have an incredibly special guest here today. I have Dr. Fauzia Riaz, who was actually my treating oncologist from many, many years ago. I don't think I would have started Manta Cares without her. No way. She was the first person to encourage me. But I'm pretty sure I drove her a little bit crazy, which she will never admit. But Dr. Riaz, thank you for joining us today.
No, thank you so much for having me, Samira. And I think you're a little too hard on yourself.
Dr. Riaz, when I met you, I was thinking about this. I think it's almost 5 years.
I was actually thinking the same thing. I was like, has it really been that long? Time really flew. Time really flew by. Yeah, I think we met about 5 years ago.
I think almost to the date. But I remember you had just joined Stanford. So my very first question for you is, why did you get into oncology? And what made you come to the West Coast?
Oh gosh, that's a good question. So I think why I went into oncology, ultimately I think that, it's about the patient, right? And I think I think the relationship between a doctor and their patient is just so special. But I think when it comes to an oncologist and their patient, it's just even more profound, right? You're really treating people and taking care of people at their most vulnerable time and in their life. And I think that in itself is it's an honor to take care of people in that capacity and to have that level of trust and connection with your patients. I think it's also, one of the most rapidly evolving fields in medicine, right? I think we are seeing science happen in real time, and we're seeing, treatments become available to patients. It's just amazing to see how rapidly the science and our understanding of cancer, and in particular breast cancer in my case, is evolving. And what brought me to the West Coast? Well, ultimately, it was a job, actually. I think, it's very interesting to say that. But when I interviewed here, I think the people at Stanford, I think I couldn't ask for better colleagues. I think we all work very well together. And so I think for those reasons, right, I came out to the West Coast, which is such a huge move for me. But yeah.
Can you tell us where you grew up?
So yeah, I grew up in Florida, actually, born and raised. My parents actually still live there, and so it was a very, I grew up in a very close-knit family. I have 4 siblings. My father's actually a physician. And out of the 5 kids, I'm the only one who decided to go into medicine.
What?
Isn't that interesting?
I didn't know this about you. I didn't know you were one of five. I didn't
I
even know
am
you
one of
had
five. Yeah.
Wow. Wait, what
It's,
order? I need to now I need to know what order.
well, I need you to guess, actually,
Oh,
Samira.
God.
You've got to guess where I am.
I think you're the youngest.
I'm actually not. I'm the second eldest. I'm the second eldest.
Wow. Okay.
Yeah.
Huh.
Yeah. So yeah, that was where I grew up. And then, I lived actually on the East Coast my whole life up until I moved out here. So, it was I moved out here right before the pandemic, actually. So that was an interesting time to move.
I remember because
Yeah.
I remember lockdowns. I think we had I'm saying we but I
Yeah.
think we had one chemo cycle pre-lockdown. And then
Yeah.
everything
I was actually, yeah, trying to think back. I think we actually met before lockdown, and then everything else was after. And I think I truly felt for my patients because, you're going through something so challenging. And so the physical, not only the physical impact, right, of treatment, but the emotional and the psychological impact of the diagnosis and the treatment as well, of course. But so many people had to, go to these initial appointments on their own and, start treatment on their own. And I think that was the side of the pandemic that people don't necessarily think about, right?
I was thinking about you recently, and
Hmm.
not just because we had a podcast episode scheduled, but more because I was reading something about the emotions of cancer and how a lot of clinicians actually don't bring it up. And I
Yeah.
distinctly remember you bringing it up not once but multiple times and
Yeah.
checking on me. And I remember being completely thrown by it because I'm so not used to clinicians asking me that question. But now that I know you, I know it's part and parcel of how you see care. So
Yeah.
I'd love for you to talk about that. Where did you learn that?
Well, I hope it's partly maybe part of who I like the environment I was raised in. I think that hopefully contributed a little bit to it. I think that I think the human experience, and I think going through something like this is just so challenging. And especially, when I saw you, right, you were you were in your early 30s at the time. And so, I think that really stood out to me. But regardless of age or anything, I think, going through something like this, right, there is the physical impact. But I think a lot of times, right, it's so important to look at the emotional and the psychological impact, because I think not only is that just important for someone's well-being, but I think it also influences how they tolerate treatment. And I think just throughout my training, right, I think I was just very fortunate to learn from and, witness incredible people who exemplified, I think, what it really means to be a compassionate and attentive physician,
Mm.
right? And, I alluded to this earlier. I think the doctor-patient relationship is just so special. And I think in oncology, right, it's even more. And people are facing some of the most challenging times in their life, and I think it's important to acknowledge that, and provide support there where we can. So
Dr. Riaz, you said something that struck me, both compassionate and attentive.
yeah.
Compassionate makes sense for me. Attentive is an interesting one because I think as a patient you just assume that your clinician is attentive, but then
Well, I think attentive to all parts of the care, right? Not just the cancer treatment, but just attentive to, how this is having an impact on, other parts of your life and other parts of your well-being, right? This, like I said, the emotional and the psychological components, because it's, where that's not necessarily something that's taught in textbooks, right? You're taught to treat the cancer. You're taught to, manage the side effects of treatment, and but you can't necessarily you don't teach the other side of it, right? And so when I said attentive, I meant, paying attention to how this is having an impact on other parts of your life.
Fascinating. Can I use that as a jumping point off into survivorship?
Sure.
Can you maybe just start by defining it for us? Because I know that there's a lot of back and forth in the community on how you define survivorship, sort of formally and technically, how patients
Yeah.
see it, how clinicians see it. Just a little bit of definition, that would be great.
I think it's a huge, it's an umbrella term, right? And I think it's focusing on, recovering, of course, from treatment and from the diagnosis. But I think it's, I think it's recognizing that cancer care extends beyond the initial diagnosis and the initial treatment, right? These are life-changing diagnoses that there's often, major surgeries involved, right? That can, change how people physically look, how people's appearances, right? And so I think that has an impact on so many facets of life, right? Like not just, so I think that's what survivorship in my mind is that, treatment and caring for the person doesn't stop when the kind of that primary treatment of the cancer stops. And it's making sure, right, that the person is not just surviving, but thriving, right? That you're able to get back to as normal of a life as possible, right? There's, normal being, who knows what normal is, but yeah, it encompasses a lot. And I think if you ask someone else, they may, like you said, there's maybe a lot of definitions out there, but for me, it's providing, the emotional support, the rehabilitation, just getting people back, into their normal schedule, their normal routine, and not letting the cancer diagnosis be the defining part of their life, getting people into wellness programs, all of those things. So I think it's really focusing on regaining quality of life and sort of just being able to move forward.
Dr. Riaz, how do you see survivorship different between early breast cancer and metastatic?
I think what we traditionally think of with survivorship is in the early stage setting. But I think it's also very important for those who have metastatic breast cancer, right? People can live for years. Thankfully, like our treatments are getting better and better, and people are living longer and longer with metastatic breast cancer. And I think that's the key, right? Like they're living with metastatic breast cancer. And so I think it's important that, just because someone's coming in to see you for the treatment of metastatic breast cancer doesn't mean that they don't need some of these same support systems. And so, we know that things like being able to exercise and being able to have kind of that performance status is associated with better outcomes. So I think I would say it's, just as important for those who have metastatic breast cancer.
Maybe we can use that as a branching point into the study. Maybe we just start there. Can you just summarize the study for us and give us your overarching insights from it?
Yeah, no. So this is a very interesting study. And so, yeah, thank you for sending it to me for review. I think, I'll first start off by this study was a monumental effort on the part of the authors and the part of the investigators. And I truly commend them for that. I think, they surveyed over 1,000 or almost 1,000 people at 3 different time points and over the phone. Gosh. But I think this is always a very challenging field to study, right? But essentially, the study was looking at understanding different survivorship care models across different institutions, and across different diseases, sort of, at baseline 3 months and 6 months, and ultimately trying to understand if there's an association between quality of life and the particular care model that was used. And ultimately, they did not see an association between that. So I thought that was actually pretty reassuring to hear, right? Ultimately, what I took from that was, well, survivorship in whatever capacity you can give the patient is what matters. And although they included people with prostate and colon cancer, in addition to breast cancer, vast majority of the patients did have breast cancer, were breast cancer survivors of breast cancer. And so I think that's, a major limitation of the study. We can't really, generalize this to the, entire population of people who have cancer, or even I would even argue maybe even the population of prostate and colon cancer, population of people with prostate and colon cancers. I think this is, much more specific to those with breast cancer. Even just looking at the factors, right? The different components of quality of life that they focused on really was much more relevant to people surviving from breast cancer than those with prostate and colon cancer. So, and it makes sense, right? Because most of the patients were those who have breast cancer. But I did, it would have been nice to see it kind of be a little bit more generalized. I think it was also very interesting that they characterized, the time since diagnosis. They did categorize patients, up to 6 months, 7 to 12, the 13 to 24, 25 to 60, and then basically over 5 years. I thought that was great, but it would have been nice to maybe see how things are different between different time points, right?
Yeah.
But yeah, again, I think this is an important question to ask and to study and to understand, because we want to make sure that whatever model of care we have in place is going to be the most effective. And like I said, reassuringly, they didn't necessarily see an association between the quality of life, the impact on quality of life, and the care model that was used.
Dr. Riaz, one thing that struck me when I was reading it is when I was looking at quality of life as a sort of definition, and when I was reading what are the things that I'm looking at underneath it, things like fear of recurrence are in there, financial worries are in there, fatigue, of course, you're like more sort of quote unquote standard symptoms. The thing that I am sitting in is I know as a patient, fear of recurrence is debilitating, is the nicest way to put it. Definitely been there. But from a healthcare system perspective, from a clinician perspective, how does that show up? Because fatigue, like, a symptom, a physical symptom, is to some extent, I imagine, easier because I can just be like, Dr. Riaz, I'm tired.
Yeah.
But me coming to you and telling you, Dr. Riaz, I'm terrified of my scan. I personally don't show up that way, I think.
No, I hear what you're saying, right? I think from the clinician standpoint, maybe having, I think very much the fear of recurrence is, I think, very universal, right? I think those are the things that I hear about the most, right? Fatigue and fear of recurrence, right? What you're saying, as that tends to be the most commonly mentioned concerns. Fear of I would maybe argue, and I'm just sort of thinking out loud here, but I find that fear of recurrence, right? It's debilitating, to use your words, debilitating from your perspective. But as someone who, right, has the knowledge of the disease, I feel like I can provide reassurance and, sort of ground the person. And I hope I do that for people. And so I find maybe that actually is in some ways less challenging than fatigue, Is fatigue, I mean, like I said, right, our goal is to try to get you back to feeling, how you were before, not how, but as close as possible to before treatment. And fatigue can be a constant reminder of what you've been through. And it can, it's a very real symptom. And I think it can definitely affect quality of life dramatically. And fatigue can just be so multifactorial. And so trying to recognize what is the primary driver of the fatigue, I think, can sometimes be more challenging than sort of grounding the person and talking about their risk of recurrence and sort of hopefully providing reassurance. So
That's fascinating. I never thought of it that way. It's very interesting.
But it's different, right? Like your experience is going to be very different than what your perspective is very different than mine. And I think it's, very important for me to know that, that someone has a fear of recurrence. And I think it's almost expected, right? But yeah.
And then as a follow-up to that, and oncology is changing a lot. So we have all these new models coming into the world. Sorry. My brain switched for a hot second.
No.
But how do you see like long-term survivorship? Like who, for lack of a better word, owns that relationship? Because
yeah, that's a good question, Samira. You're asking me to I think it should be owned by everyone involved in the patient's care, right? And it shouldn't just start when someone finishes their treatment. I think that it should be integrated from the beginning, right? I think focusing on things like long-term physical and emotional and psychological effects of diagnosis and treatment, it should be really starting from the beginning and focusing on those things in addition to the treatment should be there, constantly. So I think it's probably, I don't have a great answer for you, Samira, but in my mind and how I sort of see it is, as the oncologist, right, you're starting that. And then, after some time, people can graduate from clinic, from seeing their oncologist. And that's where, maybe the primary care doctor or primary care provider can take that baton and continue. And, and then there are specific survivorship models, right? Like survivorship clinics. And so those, clinics I see as a partnership between the primary oncologist and that particular clinic. So yeah, I think there's a lot of facets to it. I don't know if I have a great answer for you, but that's sort of how I see it.
No, that was a great answer. I think it's that's kind of what I was alluding to in that, because I ask oncologists this all the time. And it's been fascinating for me. I think if you look back like 2.5 years, I know you and I spoke about this because you were insistent I got myself a PCP. And I remember that. You were like, you have to get a PCP. I was like, Dr. Riaz, do I really need a PCP? And you're like, yes, you really need a PCP. I remember you.
Look, I just want to make sure that we're not just treating the breast cancer, right? We're also making sure we're not, we're not ignoring other very important parts of your health maintenance and your health care.
It's that
you were very resistant to it too.
I have a phenomenal PCP. You will be proud of me. She's amazing, absolutely phenomenal. But yes, it took me a long time to get there.
I know.
I think it actually goes back to where you opened. I really think it goes back to that, right? It's the oncologist-patient relationship is just different.
Yeah.
It's so different than any other clinician relationship. Because with your oncologist, one, you see them a lot, and two, It's
Yeah.
just, it's like you're helping me live. There's just such a foundational
Yeah, no, you're
emotional
right.
piece there that I don't think is there with other professions necessarily. And I've learned though. You will be proud of me.
No, I know you're stuck with me, Samir.
All right. So on that note, can you talk to us a bit about the two models the paper had? That was like the specialized, consultative, and the oncology embedded.
And what I guess I was trying to get from the study, I think those are maybe, I mean, I think those are, models of care that are being used, but yeah, they basically they sort of identified those as the kind of like the big categories. And so what I imagine, right, oncology embedded survivorship is sort of maybe the model that I was referencing, right, where it's survivorship care that's sort of seamlessly woven into the care of the patient, right? Not just once they finish treatment, but early on as well, right? Like when not really thinking of survivorship as like a separate phase that starts after treatment ends or like active treatment ends, but rather as a part of their oncologic care. Um, Whereas I think the consultative, what was the term they used? Specialized consultative model. It's, I think, more of a model of survivorship where people are referred to like a dedicated survivorship clinic or,
Hmm.
sort of a specialist in survivorship post treatment. And I think there's a role for both, right? I think that, the support systems of a survivorship clinic are different than, someone who is the primary oncologist who was, much more focused on the active treatment. So I think there's pros and cons to both. But I think it also integrates right survivorship care into oncology treatment, but in a different way. And so this is more of like a focused, maybe expert driven care. And I think one of the nice things about this study was it didn't matter what model was used, right? At the end of the day, there didn't seem to be an association between quality of life and the specific model. So I think, as I mentioned, I found that to be very reassuring about the study. I was actually, if we look at the population, I think one thing I found a little disheartening was the people who had the lowest income were also those who had, they were the lowest percentage of the lowest proportion of people who were actually getting survivorship care. And I think that I think spoke volumes to me. And so I think we need to look into, I think that's one thing we need to look into is, making sure that survivorship care is available to everyone and accessible to everyone.
I'm going to use that to pivot a little bit
Mm-hmm.
because you and I were going back and forth on email. And here's my question for you. So you
Mm-hmm.
recently, I think, if I remember right, I'm going to use the wrong words, but also took on a research hat more explicitly.
Mm-hmm.
So maybe you can talk to us a bit about what your research interests are outside of survivorship.
Of course, right. I'm a breast cancer oncologist, so a breast oncologist. And so for me, my interests are really, my research interests are looking at novel therapeutics, novel approaches to treating people who have cancer, both early, early stage treatment optimization, but then also looking at, novel ways to treat those who have metastatic breast cancer as well. Um, I think the other, the other part of my research interests are is looking at distance, right? And distance and accessibility of treatment. Because at the end of the day, right, if we have the best treatment available for some, for cancer, if people can't get to it, if it's not an easily accessible treatment, then we haven't really made a difference for people, right? And so I think one of the things that I was struck by when I moved out to the West Coast was that people travel very far for treatments. And I think that's a real factor to take into consideration, right? So I did my fellowship at Yale, and so it's in sort of the Northeast. It's in the Northeast, but if you look at a map of NCI designated cancer centers, you see just this huge concentration of cancer centers in the Northeast, but across the rest of the country, they're much more spread out. And so, I think that was one of the major things I was struck by. I had people flying in from Hawaii, coming in from like Eastern Oregon, driving 6 hours plus each way to get their care. And so that struck me as, something that, we need to do better, because that's a lot of time to spend on your treatment. And especially for people, right, who have metastatic breast cancer, where treatment is indefinite.
Yeah.
You think about the toxicity of time or time toxicity. And so, just looking at how we're delivering cancer care to people.
Wow. I forget the number. How many are NCI designated? We have.
Oh gosh, you're asking me a question I don't know the answer to. Let me look. I can look. Let's see. No, I mean, if you look at a map, right there, it's I guess 72, maybe, and then 50. Yeah, there's 72 NCI designated cancer centers.
I can see the visual in my head, and I actually want to link it, because you're totally right. If I remember the maps I've seen, there is such a cluster there, and even the West Coast, it's a little bit of a cluster in the north, cluster in the Bay Area. I think, if I'm not mistaken, at least there's a handful.
I mean, it's us and UCSF,
right,
and then UCLA is the next one further south. So,
so everybody else, you're basically commuting then if you want to go to an NCI designated center.
Yeah. So it's very spread out. And, I remember when I was a fellow, we'd have people coming in from, for example, like from New York, and it would be a 2-hour train ride. And in my mind, I thought I was like, wow, you're taking a 2-hour train ride for your treatment, but here, it's like, I realized that was nothing compared to what people, do out here, right? And when treatments, and that's where I think we can make a big difference, right? Of, how are treatments administered? What is the schedule of treatments? And so these are all things that I'm, very much interested in, beyond, right? It's so important for us to understand and develop treatments for breast cancer. And that's very much, something that I research. But I think also in that same, that same process, right, we need to be thinking about what access and accessibility looks like for treatments. So, yeah.
What's striking me is I think you and I had a very relatively early into treatment. I remember you talking to me about sub-Q.
Mm-hmm.
I think there was a trial going on. And I think we may have spoken about pre-pandemic, and then the pandemic happened, and everything was like kind of fuzzy as to what was going to happen. But I think I'm connecting the dot between sub-Q and time toxicity and commuting.
Yeah, I mean, even so, what you're referencing was giving some HER2 targeted antibodies now subcutaneously rather than as an infusion. And so quality of life wise, right, people can maybe get their port removed a little earlier. People come in, they get their injection, they get their subcutaneous injection, and they're out much faster than if they're coming in, they're getting their port access, then they're getting their treatment as an infusion over, and so it's much less of a process, and from a time standpoint, right, much less time for people. So that, I think, now the goal is, right, how can we get access to subcutaneous treatments more effectively for people who live further away, right?
Fascinating.
Yeah.
Very cool.
Sort of what is the next horizon of care, right? I think this is before my time, of course. I think, a lot of treatment used to be given much more inpatient. Now it's become much more outpatient. And is there a movement to try to get more treatment, even can some of it ever, be given at home, right? Some of these subcutaneous treatments, in particular, the HER2 targeted antibodies, that I hope is the next horizon of care.
That was actually going to be the question I was going to ask you, and then close the podcast around that. So you may have beat me to it. But let me maybe ask you a similar question in a slightly broader way. Like if you look out 5 years, and it could be sub-Q, it could be anything that comes to you.
Yeah.
Survivorship or not. If you look at 5 years, magic wand, you have no constraints.
Okay.
Well, what is oncology? And you cannot say cancer goes away. Sorry. As much as I want that, that's not an answer. So outside of that answer.
I know you. I knew you wouldn't accept that answer. Actually, I was gonna say, and then I was like, "Oh, Samira's not gonna like that one." I think thinking again more about how we're treating people, optimizing their care. Right. I think, not everyone needs. I think we're realizing, right, that maybe we're over treating a lot of people. And so I think treatment optimization, I mean, you and I have had multiple conversations about this. But, treatment optimization, I think, is going to be so important. And I think we're developing tools to better understand who would actually benefit from, escalated treatment versus de-escalated treatment. And I don't like to think of it as escalated or de-escalated, but rather like optimized treatment for each person. And I think that's where I see the treatment of cancer going.
Very cool. I love how you ended. I actually wrote that down. I heard you say it. I heard you say treatment optimization, and I was like, Dr. Riaz, we have to have a conversation about that.
We've had many. I know you and I have had many discussions about, convincing you to do treatment.
No, I appreciate that. I think that feels about right.
Yeah.
Especially given how much option sets there are now.
Exactly.
And I think to the points you're making, accounting for time and logistics and accessibility and personal life.
It's not just the toxicities of the drug, right? We have to think about financial and time, and all of those things are just as important.
Yeah.
So, yeah.
Well, I appreciate your future vision. Very selfishly, I think it's great.
It's been so fun talking to you. So thank you so much for the invitation.
Thank you for coming. Thank you for being a very, very special guest for me. And thank you for saving my life. I literally would not be here without you.
That's you did all the hard work, Samira.
I really did. I think my parents did.
You have a wonderful support system, wonderful family around you. So yeah.
Thank you so much. I appreciate you. This podcast, show notes, and newsletter is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice, and no doctor-patient relationship is formed. The use of information on this podcast or any materials linked from this blog is at the user's own risk. The opinions of the speakers are their own and do not represent the opinions of organizations they're affiliated with, nor do they reflect the opinions of Manta Cares Inc. or Manta Cares' sponsors. This episode was supported by an award from the Patient-Centered Outcomes Research Institute.